Hi, my name is Dr. A.B. Mendelsohn, and today we're going to talk about sialendoscopy. So salivary glands are somewhat of a mystery to a lot of people, but we have thousands of salivary glands throughout our mouth and throat. But there are four major or main salivary glands, two within our cheeks and two right underneath our jawbone, which is called our mandible. So these are called our submandibular glands, and the ones in our cheeks are called the parotid glands. The main function of the salivary glands is to produce our saliva. The saliva is so important for so many aspects of our mouths and oral hygiene. They keep our teeth healthy, they're important for taste, comfort's important, they're important for immune functions, they fight off infections. There's so many aspects of what saliva does for us. So these saliva glands in our face and our neck, they're pumping in all the saliva, which is important, but every so often these glands can either get infected or, more importantly from a sialendoscopy standpoint, the flow can be obstructed or blocked. So the most common cause of salivary flow blockage is going to be from a stone. People are very shocked to hear that stones can actually form in the salivary glands, but it's very similar to kidney stone, meaning the actual stone itself, made up of calcium, will form within the tubing or the ducts of the glands, and just like that kidney stone blocking off the flow, very painful, causing a lot of problems. We really don't understand the risk factors or why one person might develop a salivary gland stone as opposed to someone else. People will report, oh, I drink a lot of water. It's not about dehydration, which is actually a risk factor for kidney stones. But we turn into a little bit like plumbers. It stinks that you got it, but we're gonna go in there, we'll get it out, we'll clear the pipes, and you're gonna be good to go. What we do traditionally is we have to make a cut on the skin, go down, remove the gland, and now the gland is no longer in the body. There's a lot of surgical risks, there's a scar, and so the nerves in that area can potentially be damaged, and obviously people don't want organs of their bodies removed if they just don't have to. It's a stone issue, it's not a gland issue. This option of sialendoscopy allows us to go in there, first figure out or diagnose what the cause of the obstruction is, and in about 95% of the time we can remove it at that same time, whether it's a stone or it's a scar or stenosis or whatever is the cause of the blockage. Not only can we find out what's the problem, is actually fix it right then and there, and we're preserving or saving so many glands as we continue to roll along. So under general anesthesia, I go in there, identify the opening to whichever gland we're addressing, and sometimes it's more than one gland. We can do it at the same time depending on what's going on with the patient. Identify the opening, stretch it open gently. We're only looking to get that opening of the duct about 1 to 2 millimeters to fit these tiny cameras in there, these endoscopes. See what's going on in there, and sometimes we're like, oh, there's a big yellow snowball, which is the salivary stone. See it, see if we can capture it with one of our wire baskets, go ahead and pull it on out. We need to make a small incision, we can do so. And then the question is, well, how do you close any incisions? And importantly to note that we're not closing anything, we're doing the opposite, we want to keep it open. Let's say you remove a stone and you close it, the scar could cause as big or more problems than was going on with the stone. So when we do our repair, so to speak, the actual stitches are absorbable, but they're used to keep the duct open so it can continue to flow. So during the procedure of sialendoscopy, there's no pain. Patients are sleeping, absolutely no pain. When they wake up, most commonly they're experiencing something along the lines of dental pain. So you had some deep cleaning or even a tooth extraction. So there's some soreness, but Tylenol, Advil is generally plenty. So sialendoscopy is a little bit like a fishing trip. We don't really know what we're gonna get. We don't really know how, even if we know there is a stone, we don't know how much it's gonna fight us coming out like any good fishing trip. So on average, sialendoscopy takes about 45 minutes, but sometimes it can go up to an hour or even more if necessary. The main risk that we need to discuss is the fact that it may not be successful. Overall, it's a 5% risk. So if patients aren't okay with the possibility of going to sleep and waking up with the problem not solved, then that's a different discussion that they may not be right for sialendoscopy. But overall, the other risks are very much similar. Bleeding, nerve dysfunction, infection, all these are very low risk and it's a very well tolerated surgery.